Director uh, Deputy Secretary NCT Sarita Nair Madam, and all the participants have been speakers as well as the participants who have joined us from all over the country. Ma'am, we are joined by the state nodal officers of NCD. The NAFED component is covered under our NCD program. State nodal officers, the district nodal officers of NCD, as well as the medical officers who are working at CNCs and the PHCs. So we have more than 4,000 registrations and around 2,000 employees. So we today commemorate Global Fatty Liver Day 2024. And the significance of this day lies in the fact that with increasing incidences of obesity and diabetes, which the main cause is the intake of excess calories. So when the excess calories are taken and the liver is not able to process them, then it tends to give rise to a condition known as the fatty liver. And we have Dr. Shiv Kumar Sareen sir, the director from the ILBS. Sir will be taking a technical session on reduction in NCDs through liver health. After that, Dr. Ashish Goyal sir, Professor Hepatology, CMC Vellore, will be talking on diagnosis and management of NAFLD and NASH. And after that, from the NAFLD, from the NPNCD program, NAFLD services component will be discussed upon. So, to begin with, I would like to request Dr. L.S. Kosticharan sir for the welcome address and to address upon the things of this.
Good morning, ma'am. Madam L.S. Junction, Additional Secretary, Policy and NCD for Ministry of Health and Family Welfare. My colleague Sarita Nair, who is the Deputy Secretary in the division, also Dr. Avinash and other consultants who are working with us here. And all of us who have joined here today online to observe a particularly very important day, Global Fatty Liver Day. Historically, ma'am, liver has always been associated famously with alcohol. So we all thought that alcohol is the main cause of liver disease and you should abstain from alcohol, which is of course still valid and correct. But with the emerging evidences, we have also come to know that many of the deposition of fat in the alcohol in the liver does not necessarily come only from alcohol, and there is a group of diseases which is non-alcoholic fatty liver disease. India has been one of the pioneer countries which could include in the operational guidelines of NCD the component of NAFLD. So we have been working towards that, and today is a very apt day for celebrating that inclusion, and we will be working towards the better implementation of the NAFLD component. Ma'am, when we have the lifestyle diseases approach for any health, we should start with the risk factors. So we should have seen, at a young age, deterring people to initiate tobacco use or alcohol or any of those unhealthy habits, including unhealthy diets, etc., and increasing physical activity, etc. We should have done that. But unfortunately, many of us were not able to do that because of various social factors, economic factors, and we proceed in our life risk factors inbuilt in them. And our role in the NCD program comes here in where we need to prevent them from doing it, and those of the population which has escaped and gone ahead with having those risk factors, we should be able to screen them. So we are able to do that over 30 years and above by the CVAC form that we are administering through the ASHAs, and also increasing the awareness about the risk factors they could be having, and then we also screen them for the common NCDs, particularly hypertension, diabetes, and the three cancers. And now, ma'am, if we are able to catch them here and prevent them and put them on standard treatment guidelines, many of those catastrophic health effects would be now catered to. But we still have a challenge in doing this. Many of them do not come into the net of screening. Many of them do not come for the health seeking behavior, and we still progress ahead in the disease paradigm as well. So the next step, which we should also do concurrently, not necessarily that we keep waiting for these people to come, but the next step we should do is looking at the liver. Liver would, as experts here, elaborate more, like Dr. Steve Mastery himself is a doyen in liver care. They will tell us that we need, if we have the opportunity in the health system to look at the liver, then we'll have a lot of best buys for NCD control. So that is why today's workshop is very, very important, and we are happy that, ma'am, you are here to grace this occasion to increase the visibility of the program, as well as emphasize once again to all our colleagues in the state and the district, so that the NAFLD component may not remain as something new, something difficult. We are here to help them implement that component. We are here to, clear the doubts. Dr. Sarin will be here for clearing all the doubts and also raise the importance of the NAFLD component. And today's workshop, we are happy that we have more than 2,500 already listening to all of us, and we are all eager to hear from you and other experts in today's webinar. Thank you.
Thank you, sir, for those opening remarks. Now we would like to request respected Additional Secretary L.S. Johnson, Madam, for her guidance as to how we should move and continue to address the issue of NAFLD under NPNCD. Over to you.
Thank you. A very good morning to all on this occasion of the Global Fatty Liver Day. Respected Dr. Shiv Kumar Sareen, Director ILBS, Dr. Ashish Goel, Professor, Department of Hepatology, CMC Vellore, Dr. Swasti Charan, Additional DDG and Director EMR, Directorate General of Health Services, Dr. Avinash, DAPG and CD, Deputy Secretary Sarita Nayak, and the entire NCD team here, all the eminent professors and clinicians and academia who are with us in this webinar today. My greetings to all of you on this occasion. We have gathered on this very significant day to observe the Global Fatty Liver Day. And as pointed out by the speakers ahead, that in India, we are seeing an increasing trend of non-alcoholic fatty liver disease, NAFLD. So this is a matter of great concern given our huge population and given our kind of lifestyle, the way things are going now, and there's a tremendous increase in all these associated comorbidities of hypertension, of diabetes, and now about the liver-related diseases, especially NAFLD. So while we are at the same time battling diseases concerning the liver, including viral hepatitis, and then due to alcohol, cirrhosis, and cancer, it is time, I think, that we pay much greater attention to this issue of NAFLD. In the ministry, in our health programs, so far in non-communicable diseases, we have been giving a lot of importance to cancer screening, oral cancer, breast and cervical mainly, and population-based screening for hypertension and diabetes. But of course, directly for liver-related, we have not been able to make much of a breakthrough. This is the right time, I think, this coming year that we frame a concerted program towards addressing NAFLD. I would request my team and also all those who have joined in here to put your experiences together so that we can chart out one program as such for liver-related diseases. In the ministry and at the state levels, this effort does require a lot of coordination, interministerial, intersectoral, because all said and done, awareness and prevention is the key. There is not much awareness, I think, about non-alcoholic fatty liver disease. In fact, many people think that just by, not by avoiding alcohol or tobacco, then they are protected from this kind of disease. With any disease related to the liver, especially non-alcoholic fatty liver. And it just shows that we need to do so much more about awareness, how we can avoid this right from the school level, from our curriculum itself, building in awareness about what kinds of food to eat, what kinds of lifestyle, what activities we need to pursue. We have the Fit India movement through Ministry of Sports, we have the Eat Right movement, and we have so many other initiatives, including the Ayush. The yoga is known to be one of the great factors which can help in maintaining a good lifestyle and a healthy body. So I feel that, in short, we need to work together, come together, and have your outreach in a focusing manner as a campaign, and also try to bring it down to a population-based screening in ways that are possible. I'm sure with this, we will be able to bring in much more awareness about liver-related diseases and how they can be prevented, and when it occurs, how we can take better care and assist and help our population who are suffering from this. So with this, I want to extend my appreciation to everyone who have joined us today and request them to take this message forward and to bring in more awareness. I would especially like to appreciate and thank our guest speakers for the technical sessions, Dr. Sareen, whom we all know is an authority on this subject, and Dr. Ashish Goel, and all the others who will be joining us. I look forward to hearing more technical sessions and look forward to the growth and expansion of this particular component of the non-communicable diseases program. Thank you very much, Jay.
Thank you, ma'am. Thank you for that encouraging words, and specifically I that raising the awareness around the issue of NAFLD is very important, and we all need to address that concern under the program, and we shall all be under your guidance. We shall all be doing it. Now, next we have the keynote address from the respected Secretary, Health and Family Welfare. We have a recorded message from Sir, as Sir could not join us physically. So I would like to request the team to kindly play the recorded message.
Morning, colleagues from the Ministry of Health and Family Welfare, from the states, and all those who are joining in today in this very important seminar on the Global Fatty Liver Day, which we are celebrating on 13th June 2024. And especially Dr. Sareen, Dr. Ashish Goel, and Dr. Avinash Sunthalia, who will be presenting the technical sessions later on in this webinar. So it is indeed my pleasure to be amongst you who are running this flagship program of non-communicable disease in the country. And within that, the Global Fatty Liver Day, which we are celebrating today, is a very important component. I am told that non-alcoholic fatty liver disease is emerging as an important cause of liver disease in India. In India, NAFLD could be assuming a silent epidemic with its community prevalence ranging from 9% to 32%, depending on age, gender, area of residence, and socio-economic status. That is, we are saying that 1 in 10 out of 10 persons, 1 to 3 will be having a fatty liver or related disease. India contributes high numbers for the non-communicable disease globally, but the core causes of metabolic disease is in the liver. Realizing this growing burden and urgent need to address it, India became the first country to integrate the NAFLD in the national program of NCDs in 2021. As we all know, once the disease develops, there is no cure available, and that the prevention is better than the cure. Therefore, health promotion and prevention aspects targeting weight reduction, healthy lifestyle, and control of aforementioned risk factors are the mainstays of disease progression and prevent the mortality and morbidity due to NAFLD. We are today observing the Global Fatty Liver Day to generate awareness about the importance of liver health, as it is a vital organ working silently many essential functions: synthesis, storage, detoxification, and carbohydrate, lipid, protein metabolism. When any of its function is deranged, it leads to disease. Liver being at the core of metabolism, NAFLD is seen contemplating in association with subcomponents of metabolic syndrome like obesity, type 2, DM, dyslipidemia, insulin resistance, and hypertension. NAFLD is also associated with cardiovascular diseases, diabetes, stroke, etc. And a healthy liver can prevent other NCDs. A higher prevalence is expected in those with overweight or obesity and those with hypertension, dyslipidemia, diabetes, or prediabetes. Preventing NAFLD will eventually prevent the metabolic syndrome and NCD. I take this opportunity on Global Fatty Liver Day to urge all to prevent all NCDs through keeping the liver healthy. So we have to follow the mantra: eat right, exercise right, and keep the liver right. So, as is being said, that the liver is the root cause of all disease, and I urge all of you to take this seminar very seriously. We will be listening to Dr. Sareen, who is the leading expert of liver disease in the country, and we hope that we will make some progress towards reducing the extent of the global fatty NACLD within the country, NAFLD within the country. Thank you.
Thank you, sir. Now we have the vote of thanks from the Deputy Secretary, Madam Sarita Nair, Madam.
Good morning, everyone. And this was the message from Secretary Sir was will motivate us to take the program forward. We thank you. And Madam Additional Secretary Madam Jackson for encouraging and supporting us to organize this webinar. And I thank Madam wholeheartedly, and I thank Swasti Charan Sir, Additional DDG, for guiding us in all aspects of the program, including NAFLD. I thank and welcome Dr. Sareen, Director ILBS, and Dr. Ashish Goel, Professor, Department of Hepatology, CMC Vellore, for consenting to participate in the technical session. And I thank and welcome all the participants who are from the state, nodal officers, NCT, the district nodal officers, the CHOs, the MOs, and all functionaries below them. And I also thank Dr. Avinash and his team for organizing this webinar. And we are able to do it because of their effort. And with that, I would welcome all the participants to take keen interest in this webinar. Thank you.
Thank you for those remarks, ma'am. Sir, I think ma'am, we can proceed for the technical sessions, and we would like to request respected Dr. Shiv Kumar Sarin sir, Director ILBS, to share his views on the topic reduction in NCTs through liver health. Welcome, sir. We welcome you, sir.
Good morning and thank you. And I'm very grateful to the Secretary Health and to Madam Additional Secretary, Madam Changson, for the kind words. And thanks to Dr. Swasti Charan, who has led this field for last many years, having understood the relevance of fatty liver and to the NCDs. Today, me and my colleague, Dr. Ashish, would try and share some concepts. I am on behalf of ILBS as well as I think on behalf of the Ministry of Health and Family Welfare. I'm so impressed that more than 3,000 people across India have joined and many more may be listening. This for a doctor is a great opportunity to simplify and communicate a public health message. I thank you all. I would like the NCD burden is about 40 million, 41 million deaths. 74% of them are all deaths are due to NCDs. And India, nearly 6 million. This data may be a little old, but 60% to 68% of all deaths are NCDs. What are NCDs? Stroke, heart disease, cancers, diabetes, chronic lung disease, and chronic kidney disease. And thanks to the efforts of the Ministry of Health, fatty liver was included last year and in 2021 as a non-communicable disease. Today, I'll try and share with you all the medical people across. You are the pillars for public health, what you need to know, what you need to do, and how to monitor. I'll cover basically the first part, and Dr. Ashish would cover the remaining. This is a simple diagram you all have read in your medical colleges, but I'll try and remind. Liver is the largest gland of 1.5 kilogram located in the right side of your upper abdomen, and it does all the work of synthesis and storage of food, including detoxification, your blood clotting, and your second circulation, which is your bile. One circulation जिसमें हमारा ब्लड चलता है और दूसरा सर्कुलेशन जो बाइल है, जो हमारी पित्ताग्नि। पर सबसे जरूरी चीज जो आप लोग शायद नहीं ध्यान दें कि आपका ब्लड शुगर की मॉनिटरिंग इज बाय लिवर. It is not by pancreas. Pancreas releases insulin in response to what the liver wants. What damages liver? You all know, and I'm sure none of you are drinking because you're all doctors, is alcohol. You also know that the 5 viruses, the hepatitis A, hepatitis B, C, D, and E. These are the 5 viruses. But probably most important today is fat. And in the context of NCD, let's understand what is fatty liver. A liver should have, of the total weight, less than 5% as fat. If it becomes double, that is 10% or more, because of either excess calories or your inheritance, and the color changes more than 10%, fatty liver. Take this as a simple ultrasound. What is fatty liver? This is the abdomen wall. This is your skin. This black is your muscle. The white is the fat underneath the muscle. And this is the liver. Now, compared to the fat, the liver is also white, bright. This is a fatty liver. Compare it with kidney, it is like dark, spleen is dark. So fatty liver has lot of fat and this is not good. What does the surplus fat do? First to the liver and then to the other organs. That is where NCDs will come. This is not a complicated diagram. Don't be scared. This is the liver. Now, except alcohol, if there are too many calories or the type of food that you have, it causes fat in the liver. Now, this is a biopsy of the liver tissue. Every single liver cell is seen, but the white cells are all fat laden. मतलब ये फैट से भरे हुए लिवर के सेल्स हैं. तो जब ये ऐसे सेल होते हैं तो बाकी बॉडी के सेल्स, जो आपका इम्यूनिटी है, वो सोचती है ये सेल तो यार गड़बड़ है, इस सेल को मारो. तो दे सेंड इन्फ्लेमेटरी सेल्स. दिस इज हेपेटाइटिस, फैट इंड्यूस्ड हेपेटाइटिस. फिर हीलिंग होगी. हीलिंग के अंदर स्कार बनेगा. जैसे हाथ जल जाए तो स्कार बनता है, तो लिवर अगर बर्न हुआ तो स्कार बनेगा. एंड दिस फाइब्रोसिस हैज लॉट ऑफ रेलेवेंस. आई विल शो. इट may lead to formation of cirrhosis, and very large 10% of them may develop cancer. But what is the readout? हमें पता कैसे लगेगा? हम तो बायोप्सी नहीं कराना चाहते. एक सिंपल ब्लड टेस्ट है, SGPT या ALT. So when the cells of liver die due to any cause, the ALT goes up. Now your liver or somebody's liver has more than 10% fat. What is the meaning? I'll come to it again. The insulin cannot enter into these cells. जिस सेल में फैट है, फैटी लिवर में, उसमें इंसुलिन घुसना मुश्किल है. तो आपकी एनर्जी नहीं बनेगी, आप काम ही नहीं कर सकते. पैंक्रियास को और ज्यादा इंसुलिन बनानी है, और इंसुलिन डेली बनाएगा तो पैंक्रियास वीक हो जाएगा, एंड फाइनली इट गिव्स अप and you get diabetes. So you have a high SGPT or ALT, and you have more insulin, and you get fatty liver. Let me make it more simple. Very, very important. This, if you understand, you have understood. This is a normal liver. इसमें ये पूरे लिवर के सेल्स हैं, हर डॉट में एक सेल है. तो एक 55 साल का आदमी, उसका फास्टिंग ब्लड शुगर 95, बड़ा खुश है मेरी शुगर, पर वो 2 यूनिट इंसुलिन खर्च करता है और उसकी शुगर 95 है. दूसरा आदमी जिसके फैट है लिवर में, ये वाइट सेल्स हैं, उसकी भी शुगर 95 है, वो भी बड़ा खुश है. ही got his sugar and he says, oh, my health checkup, annual health checkup, my sugar is all right. But let's understand little more. He uses 2 units of insulin. रात को खाना खाया, सुबह ब्लड शुगर 95 है, 2 यूनिट इंसुलिन खर्च हुई. इस व्यक्ति ने 20 यूनिट इंसुलिन रात भर अपनी प्रोड्यूस करी टू कीप ए शुगर ऑफ 95. The job is of liver and pancreas is to maintain sugar. But he uses 20 units, 10 times more every day. This is called insulin resistance. And this burns out your body. All the problems of the body, metabolic diseases, are because of this. So now I'll briefly summarize. Diabetes is a liver disease, and outcomes are worse if you have fat in the liver in diabetes. Now let's go further. अब लिवर में फैट है, भाई वो लिवर से कहीं तो जाएगी, निकलेगी. वो फैट गोज इनटू योर ब्लड. आप ब्लड टेस्ट कराने गए, आपका कोलेस्ट्रॉल हाई था, एनुअल हेल्थ चेकअप में पता लगा, आपके डॉक्टर ने दवा दे दी, कहा कि साहब ये दवाई खा लीजिए, आपका कोलेस्ट्रॉल कम हो जाएगा, ट्राइग्लिसराइड कम हो जाएगा. पर सवाल नहीं पूछा कि ये कहाँ से आया फैट. दिस फैट हैज कम from a liver which is full of fat. So everybody who has high cholesterol, high triglyceride has fatty liver. Now this fat is circulating. It goes on to your arteries and becomes the hard arteries. So you get blood pressure. Arteries are hard. You get heart disease, kidney disease. Your bones get weak. All the cancers are related. Stroke, gallbladder stone, liver से बाइल, पित्त जिसमें ज्यादा चर्बी है, वो अगर गॉल ब्लैडर में गया तो यू गेट गॉल स्टोन. सो हाउ नाउ दिस सिंपल डायग्राम, आई होप यू कीप ए क्लिक ऑफ इट, will lead to diabetes, will lead to high dyslipidemia, all these diseases. And of course, the readout in the blood is simple, 120 rupee test ALT. I wish the government runs it throughout the country for every single Indian. Fatty liver is the core to all NCDs, and today, therefore, in my mind, it is a top public health issue. The extra fat inflames liver, but frames your body. एवरीवन नोज कि भाई हीमोग्लोबिन कितना, आपका रंग बिल्कुल पिंक है, आप लाल लग रहे हो, हाँ भाई तेरा हीमोग्लोबिन ठीक है, 15 ग्राम है मेरा तो। पर आपको मालूम है कि लिवर हेल्थ का सिंपल टेस्ट क्या है? एएलटी। हम लोग भारत में 40 इंटरनेशनल यूनिट्स लेते हैं, मेल और फीमेल की दोनों, बट यूएस एनआईएच 30 और 19 लेता है। एंड आई टेल यू व्हाई वी नीड टू चेंज एट ए नेशनल लेवल दिस। High ALT increases the risk of diabetes 5 to 20 times more. Now, this Koreans are amongst the best in my mind for longitudinal health prevalence predictor studies. तो इन्होंने क्या किया, 1990 से 92 में 1,42,000 people who got health insurance between 35 and 59, उनका ALT लिवर का टेस्ट मेजर किया, and they followed them for nearly 10 years. Now see, all cause death, heart, kidney, brain or liver deaths. If your SGPT or ALT is less than 20, it is 1. But if your SGPT, ALT is 39, liver related deaths are 9 times and heart and others are 1.7, मतलब 70% बढ़ गया। और अगर आपका SGPT 40 या उससे ऊपर है, you can see it increases. The risk of mortality can be tested by one simple blood test. And let us do it to make India a better place and better understand. Now, ALT and coronary artery disease. Higher 10-year risk of coronary artery. This is a Swedish study. एक 26 साल का लड़का जिसका ALT 80 है, he has several times higher risk of heart disease by 36. अब आप अपनी लड़की के लिए लड़का ढूंढ रहे हैं या लड़के के लिए लड़की ढूंढ रहे हैं, तो जन्म पत्री से ज्यादा ALT का फायदा होगा। इस लाइटर टोन, मतलब जन्म पत्री भी बहुत इंपॉर्टेंट है, पर ALT चेक करें। क्यों? अगर उसका ALT 80 है तो 10 साल में हार्ट का रिस्क 3 गुना, लिवर का रिस्क 30 टाइम्स, एंड दिस हून स्टडी सेज इट कुड बी 7 टाइम्स मोर than a person. So 26-year-old is not healthy because of age, he is unhealthy. Coronary artery disease risk is also doubled. So to simplify in today's global fatty liver day, I would like you to understand liver fat precedes diabetes and heart disease by 15 to 20 years. 10 साल का बच्चा, 15 साल का बच्चा बड़ा होगा तो क्या होगा, उसका भविष्य लिख सकते हैं। If you have fatty liver already, then prevent development of diabetes, blood pressure, heart disease, kidney disease. You will decrease NCDs. You will decrease cancers. If you already have diabetes, भाई हो गई यार, अब तो आप डॉक्टर साहब बहुत लेट बताने आए, मैं तो 60 का हो गया, मुझे कुछ नहीं कर सकते, मेरे तो डायबिटीज हो गई। You can still reverse and actually regress all NCDs. I'll show you later. So today, NAFLD is the biggest public health issue. Reduce this and change yourself and be the change to make young India healthy. Let me simplify. This is a complicated diagram, but I'll simplify. Now, this is your bowel. आप जो खाते हैं ना, वो आप नहीं खाते हैं. Whatever you eat is processed by the bacteria in your intestine. It is also an organ. 1.5 kilogram bacteria live healthy. They are called commensals in your intestines. Now, every day you insult, रोज party में गए, you have taken different things. वो bacteria सोचते हैं लड़ाई हो रही है. Every day you are getting through invaders. This actually makes a huge difference. You get fatty liver, your adipose tissue, थोड़े दिन 3 दिन पार्टी खाई, you gain weight. Weight बढ़ गया 1 kilo. Your adipose tissue, but after that it becomes unhealthy. So an unhealthy fatty tissue, an unhealthy bacterial colonies, and your fatty liver, and then you get diabetes, heart disease, and brain diseases. And all these are related to your body's reaction to what you do. How common is fatty liver? Our very respected Secretary Health was so aware, and I am so thankful to him for giving such a good message. This is the global diagram. It's a bit old now, updated. Countries in the red are having 30% or more population with fatty liver. India is shown in red. 1 in 3 Indians. And the next century will be driven by this basic diagram. NAFLD prevalence in India. And I'll show you some data from Delhi, published just this year. What we did was we went to Mohalla clinic, general people, and we used history, examination, blood test, and elastography. I will show that little bit. Dr. Ashish will show more. Of Delhi population of 6,000, almost half of them have metabolic dysfunction, fatty liver disease. What is more important, 11% were lean and thin, वो बिल्कुल पतले थे. BMI 23 से कम, फिर भी fatty liver है. ये बात भूलनी नहीं है. And we have to remember fatty liver can occur in lean people. I've shown you now what is fat in the liver, what does it do, how NCDs, little more on NCDs. And now this is the major thing for public health. I request public health people and ministry people to remember this part, major adverse cardiovascular and cerebral events. Now, a person who has got fatty liver, 10 to 15% of them have MACE. MACE is major adverse cardiovascular events. This is influenced by genetics, by your gut microbiome, your lifestyle, and other comorbidities. But genetics is most important. We have to come to it. Now let's look at some data. Now this data is of people who have 17,000 had no fatty liver. उन लोगों का बीपी बढ़ा बहुत स्लोली 60 साल पे जाके, पर जिन लोगों के मॉडरेट या सीवियर फैटी लिवर है वो तो 30 साल से उनके ब्लड प्रेशर होने लगे. एंड इंडिया, यू नो, यंग hypertensives are more. This is a data to show you of 7 million people. 7 million people, those who have got fatty liver, they have more cardiovascular death and non-fatal cardiovascular deaths. Very clear, BP and heart disease and deaths are more. So people with fatty liver have a greater chance of, so they don't die of liver. आप कहते हो सर वो गया उसको हार्ट अटैक हो गया, उस हार्ट अटैक वाले पेशेंट का अगर आप लिवर देखें तो फैटी लिवर था 20 साल से. In Sweden, they took up people who had as a comparator healthy people, those who have just fatty liver with biopsy, with fibrosis and others. Over a period of 10 years, you will see those who have got fatty liver, they have much more. And if they have fibrosis, much more deaths in 13-year follow. Now, this is a very, very important slide. This tells you the UK Biobank. The best thing the UK people did was to set up a biobank. Biobank क्या है? आपने 500,000 से शुरू करके 5 मिलियन आदमी वॉलंटरीली अपने आप अपना ब्लड देते हैं और वो यूके बायोबैंक फ्री उसको टेस्ट करता है. अब उन्होंने 10 साल तक फॉलो किया एंड द पॉपुलेशन दे स्क्रीन्ड वाज ह्यूज. 327, मतलब 3 लाख पीपल को फॉलो किया जिनकी एज 58 साल थी. जिन लोगों के फैटी लिवर था उनको हार्ट डिजीज डबल, स्ट्रोक 30%, बीपी ऑलमोस्ट 3 टाइम्स मोर, हाई लिपिड्स 2.5 टाइम, डायबिटीज 4 गुना ज्यादा, लिवर कैंसर्स, ऑल कॉज डेथ, लिवर कैंसर्स मच मोर, सारे कैंसर्स आपके फूड पाइप के, कोलॉन के, ब्रेस्ट कैंसर. एवरी डे आई सी पेशेंट्स हु हैव ब्रेस्ट कैंसर एंड देन दे कम एंड से इनके तो सिरोसिस भी है. So this data from UK Biobank from the London population clearly says those who have fatty liver have all other causes and the cause of death more. Let's see liver cancer in India. पहले हम सोचते थे हेपेटाइटिस बी या हेपेटाइटिस सी से लिवर कैंसर। नाउ यू सी दैट लिवर कैंसर ड्यू टू फैटी लिवर, countries in maroon, the countries in maroon, India is between 35 to 40%। मतलब 100 लिवर कैंसर हैं, 100 में से 35 से 40 बिकॉज ऑफ फैटी लिवर है। We are a WHO center. We conducted a study across all the WHO centers, and it is painful for me to tell you that today, out of 100 people, 40% of liver cancer is diabetes. हम सोचते हैं डायबिटीज है, इसका शुगर ठीक कर दो, पर ये भूल जाते हैं कि डायबिटिक्स में फैटी लिवर है, लिवर का फाइब्रोसिस है और कैंसर हो सकता है। हेपेटाइटिस बी से दुगना लिवर कैंसर डायबिटिक्स में है। So please remember, your diabetes program cannot be successful unless you screen for fatty liver. So let me summarize. Fat in liver is bad. Let us look at whether overweight or normal person has fatty liver. This fatty liver is read by a rise in ALT. 20 रुपए के टेस्ट से पता लगेगा। ये फैटी लिवर डायबिटीज को, हाई लिपिड्स को जेनरेट करेगा। यही फैट जाकर के आर्टरीज में जमा होगी, बीपी बढ़ जाएगा। हार्ट के ऊपर होगी तो आपके हार्ट डिजीज हो जाएंगे। सो रिमेंबर दिस डायग्राम, यू कैन कीप इट इन योर माइंड एंड यू कैन रिवर्स इट। अरे भाई यही नहीं होगा फैटी लिवर तो बाकी चीजें क्यों होंगी? NAFLD and major cardiovascular event. Let's start some basics for children and young adults. It is very close to my heart and I want someone to pick it up. Now, this is a study of 17 million people, 17 million children. And just to tell you that in this, children who have got fatty liver have increased risk of having stroke. Now, dementia. हम कहते हैं सर मेंटल हेल्थ पे बड़ा पैसा लगाना है. Let us look at what is happening. Those who have got low fat in the liver, उनके अंदर compared to with those who have got fat, there is more dementia. अगर माइल्ड फैट है या हाई फैट है, डिमेंशिया इंक्रीजेस. बट आपने फैट रिड्यूस कर दिया, डिमेंशिया कम हो गया. Let us look at Alzheimer's disease. Those who have got liver and some liver fibrosis, they have more risk of Alzheimer's disease. We therefore need to be clear that fatty liver inflames and frames all organs. Let's look at bones. इतनी कैल्शियम, इतना विटामिन डी, भाई ये तो देखो कि रिजर्व बैंक से खींच. What is sucking out from your reserve bank? Your reserve bank is your bone. From the bone, you have drawn everything because of fat, because your weight, your bones give away everything. And osteopenia, osteoporosis, all that can be reduced, and fatty liver can be a mechanism for making your bones young. Kidney disease, World Kidney Days aate hain. People who have got fatty liver have 41% increased risk of developing CKD, chronic kidney disease, high grades. So if you want to keep your kidney well, besides their organs, remove fat. So let me summarize this part. Fatty liver is a multi-system disease. It is the key for your metabolic ill health. And your liver related all cancers, osteoporosis, karate lena hai, sleep apnea, obesity, diabetes, heart disease, and kidney disease, polycystic ovary in young girls, so common nowadays. It is because of insulin resistance. And why insulin resistance? Fat in the liver. So if you understand this circle and you know that ALT should be lower, अगर आपका ALT 10 है, so hopefully you can live 100 years. I'm sure all of you want to live healthy and you want to live for 100 years. Keep your ALT at the lowest level. And for my public health seniors and colleagues, control fatty liver to reduce the NCD burden. Now this slide is very important and is provided to me by a friend. How many times more common is non-liver related mortality than liver related mortality? मतलब एक तो लिवर के कारण डेथ हुई या आपकी डेथ हुई फैटी लिवर में, बट लिवर के कारण नहीं हुई, 50 टाइम्स मोर। तो लिवर की डेथ से नहीं मरता फैटी लिवर वाला, 50 गुना ज्यादा हार्ट, किडनी, ब्रेन कैंसर से मरता है। दिस इज ऑल्सो वेरी इंपॉर्टेंट स्लाइड, आई होप द पब्लिक हेल्थ पीपल अंडरस्टैंड। 15 साल तक फैटी लिवर है, डेथ नहीं होती 14%, पर जो ही उसको सिरोसिस हुआ या सिरोसिस के बाद जॉन्डिस हुआ या ब्लड वॉमिट हुई, ट्रांसप्लांट करना पड़ा, so you have a 15 years time before liver goes bad. This is the US study, and you have a time to improve quality of life. But more important is, if you control this, cardiovascular, malignancy, endocrine, neurological, all these things. So you have 15 years time from the beginning of fatty liver to having all metabolic diseases reversed. The cost to the society to keep a person alive till transplant is about $100,000. And in much smaller amount, a simple test of 20 rupees and a simple screening, you can change India. What you need to do, I'm not going to discuss on diagnosis and treatment. My dear colleague, Professor Goyal will speak. I may discuss briefly on this if I have time. Do I have fatty liver? और नो, इफ यू हैव फैटी लिवर, देखिए क्या बुरा हाल है बेचारे का, इसका लिवर हेल्दी है, दौड़ रहा है, एंड हाउ टू फिक्स इट. So these are simple tests for fatty liver. All of us should do it. If your family, मतलब mother, father, dada, dadi, nana, nani, or yourself, you are suffering from obesity, diabetes, blood pressure, heart, kidney, liver, cancers, polycystic ovary, you have fatty liver. सेल्फ टेस्ट, किसी डॉक्टर के नहीं जाना. ये हमारी आशा वर्कर को, हेल्थ वर्कर को सबको सिखाना. वेस्ट एंड हिप रेशियो एंड नेक सर्कम्फ्रेंस एंड योर वेट. इफ योर हाइट इज 170, उसमें से 100 निकालें, आपका वेट 70 होना चाहिए. बट अगर फैमिली हिस्ट्री है तो 105, सो योर वेट शुड बी 65. इफ यू आर फीमेल 105, so your weight should be 65. But if it is family history, you should be 60 kg on a 170. You can get an ultrasound, a fibroscan, a blood test, lipids and sugar. Now this I wanted to show to madam and all the people and public health people and ASHA workers and others. This is waist. This is hip. तो अगर आपकी हिप 40 सेंटीमीटर है फीमेल की, तो वेस्ट आपकी 24 होनी चाहिए. 24 वेस्ट फॉर ए 40 हिप. दिस इज ए वेस्ट हिप रेशियो ऑफ 0.7. फॉर ए मेल the waist should be less than 90, for a female less than 80. So teach your tailor to not fix or put jeans onto you. You should fit into the jeans. Don't fit jeans onto you. Teach your tailor कि मेरे कपड़े नए मत बनाना. Teach your children, teach the parents and your ASHA workers. And this will make a huge difference. No cost. If somebody has these black lines or these warts or moles, this means you have fatty liver. So teach your barber. भाई डॉक्टर के जाना है तुझे, तेरा थोड़ा गड़बड़ है. सो वो डॉक्टर के चला गया, हमारा काम हो गया. दिस इज द पब्लिक हेल्थ वे ऑफ टीचिंग. एंड आई एम जस्ट गोइंग टू टेल यू हाउ मेनी दिल्ली स्टूडेंट्स young 18 to 25 have it. So these black velvety lines in the front or in the back are a symbol of metabolic ill health. So now who has fatty liver? All diabetics, all those who are overweight or obese, all those who are normal or lean, but their waist is, their BP is high, their triglycerides are more, वो blood में circulate कर रहा. You have a high sugar or you have a family history. इसको photograph को रख लें. All those people who are in public health, you can manage, suspect, test, detect, manage and reverse before you get liver disease, you get blood pressure. Every fat person is not bad. This is Mona Lisa. All of us love her. But this she is from the eyes of Fernando. She is still beautiful. So every fat person is not bad. But every lean is also not good. I showed you 12% of Delhi people and many more. And this is to show why Indians are different. This is the why factor. Now this is a healthy American Canadian. Yeah, red is the muscle. This is the green is the fat, subcutaneous fat. Blue is the fat in the abdomen. मतलब पेट के अंदर विसरल फैट है. अब आप दोनों में डिफरेंस देखिए. ये इंडियन है, इसकी भी बीएमआई 22 है, पतला दुबला है ये, पर इसकी मसल्स नहीं है पेट में. इसकी ये ग्रीन ग्रीन फैट बहुत ज्यादा है. और पेट के अंदर ब्लू फैट सबक्यूटेनियस के बाद विसरल फैट 5 गुना ज्यादा है. So this is the fat in the abdomen which is the cause of all your metabolic ill health. Let me explain this further for you. This is a recent boy, 30-year-old लड़का आया. वो मोटा नहीं था ज्यादा, जरा सा उसका वेट ज्यादा था. नॉर्मल इतना होना चाहिए 65, उसका 68 था. But now you see his body fat composition. The percentage for body fat for him should be 20%. उसका बॉडी कंपोजिशन में 40% फैट था. उसकी मसल्स लेफ्ट लेग राइट लेग में यहाँ होनी चाहिए. नॉर्मल मसल, उसकी मसल्स ही नहीं है, वो देखने में फिट था. तो द एनालिसिस शोड ही नीड्स 7 किलोग्राम ऑफ मसल्स डेली एंड ही नीड्स लूज 18 किलोग्राम ऑफ फैट. इसके हिसाब से तो मुश्किल से 2-3 किलो था. और पेट पे उसके ज्यादा फैट थी, देखने में मोटा नहीं. So a lean person may have a different, and this is where the genetics come, and we need to do a large scale genetic study. I hope the government proposes and approves how Indians are different, why they are, and who are high risk predictors. I will now just show you briefly what we have done and what we should do. Efforts by India. We initiated the dialogue with the Honorable Minister and the Health Secretaries to include the public health measures of NAFLD into the national program, and fortunately Lancet covered it. This is what the Ministry, the Director General Health Services and Secretary Health prepared. This was a groundbreaking day, and for me it was a red letter, beautiful day. 21st February, we should celebrate that day also, and India took this initiative. And as Secretary Health rightly said, India, because of this, became #1 country out of 102 countries survey. India got 49 marks out of 100, and London, UK got 42 marks, and 32 countries got 0. So India 3 years ago led this field. What is the beauty of this approach? It is a bottom-up approach, not the top-down approach. तो आशा वर्कर को तो सिर्फ सेल्फ टेस्ट करना, अभी 10 चीजें पूछनी है, बाकी आगे रेफर कर देना. PHC वाला, he will identify, refer suspects, manage uncomplicated, भाई ये इंटरवेंशन करने, मेटाबॉलिक सिंड्रोम, BP वगैरह ठीक करना. इसके बाद में अगर फाइब्रोसिस है तो उसको आगे रेफर करना है CHC में, और ज़्यादा है तो डिस्ट्रिक्ट लेवल. मेजर रोल, माय रिक्वेस्ट मैडम, is that of the healthcare workers and nurses. We doctors probably are not so good in communication as the nurses and healthcare workers. We should monitor the number of people who are becoming healthy, not merely number of becoming ill. We are just having 10% diabetes, 12% this. Why can't we say India 50% healthy, 51% healthy, 55% healthy? I want to bring this slide because you have a major program of having 75 million people by 2025. And this you have obesity, diabetes, family history, medical conditions, metabolic hypertension. Please, I humbly urge all of them should be screened. They probably is the best population where you can correct hypertension. So include fatty liver screening and management of not only patients but their families into this program. Smiles is a program we initiated with the UGC between 18 and 25, Stronger India through 1 million health educated students. I know I've taken a little more time. I will run through this in 2 minutes. In Delhi, we screened about 13,000 people, young boys 18 to 25. 50% had family history of NCDs, 1 in 2. 21% were not walking. Only 1/3 of the girls had a waist of less than 80. 2/3 की कमर ज्यादा थी. 70% boys की ज्यादा थी. How to monitor and why should we do fatty liver program for NCD? This is again a study from Korea, 2009 to 2013. 3 million Koreans जिनके नया फैटी लिवर हुआ, उनका डायबिटीज बढ़ गया, हार्ट अटैक, स्ट्रोक और डेथ. बट व्हाट इज इंपॉर्टेंट एंड दैट इज वेयर द एनसीडी रिग्रेशन कम्स. जिन लोगों का फैटी लिवर रिग्रेस करा दिया कोरियंस का, डेथ वाज रिड्यूस्ड बाय 17%. कोई खर्चा नहीं हुआ, कोई ज्यादा मेहनत नहीं. इट इज द अवेयरनेस एंड द पब्लिक हेल्थ अप्रोच ऑफ द गवर्नमेंट. Fatty liver regression is our target. How much we do per year is what is important. And this is what Lancet covered last year for us. We are having an increase into all NCDs, and by 2033, we want a decrease. We want nurses, we want our healthcare workers to be part of this program. There are several public health initiatives. We need to reduce NCDs, control fatty liver to reduce NCD burden. Your liver never becomes old. This is Prometheus, who was punished by the other gods or people because he brought fire to mankind. तो दिन के टाइम में उसका vultures were nibbling the liver, but liver regenerated at night, and you never have an old liver. Dr. Kalam gave when he was our chancellor, donate your liver. But remember, night में liver regenerate करता है. So give rest, don't eat at night. This is my last slide. The NAFLD as a cause for NCD reduction. 30 crores have fatty liver in India. It's core to most of your metabolic diseases. High ALT correlates with metabolic syndrome. And Dr. Goyal will tell liver stiffness is with all other organs are stiff. Weight loss is good and statins are good. I would like to give you a simple message. All medical doctors, health professionals, and maybe administrators, you be the change and bring the change so that a healthy liver, a healthy India, all NCDs reduced. Thank you for your time. And I am very grateful to Ministry of Health for having taken this proposal, initiative, and taking it to a greater heights. India will remain number one. No country till date has 6 organs except India in their NCD division. India is the only country, and thanks to your vision and thanks to your support.
Sir, thank you so much for that detailed, insightful, lucid, simple presentation wherein you have very minutely explained the largest organ of the body, and we have very well taken your message for healthy liver, healthy India, and you have very also emphasized that liver fat precedes diabetes and heart disease 15 to 20 years. So if that is something which is monitored prior to onset of disease, and we can stop the onset of disease. Also, how you have linked healthy liver to prevention of diabetes or CVDs, as well as dementia and CKDs. How fatty liver is linked to dementia and kidney disease. And I think we need to strengthen the health promotion movement as well, the Eat Right and Fit India movement, so as to reduce the consumption of excess calories, Another, your message is also very well taken, that don't eat at night because liver regenerates at night. So we are joined in by more than 4,000 participants from all over the country, the district, the state nodal officer center, as well as all the primary health centers in the country. So this message has all percolated down to the grassroots, sir. Thank you for your insightful insightful remarks. So we all look forward to healthy liver to reduce the disease burden of NCDs in the country. With that, we move to the next presentation. Dr. Professor Ashish Goyal sir from CMC Vellore Department of Hepatology. Sir will be speaking on diagnosis and management of NAFLD. Over to you, sir.
Thank you. At the outset, am I heard properly, sir?
Yes, sir. Welcome, sir. You are audible. Welcome.
Yes. At the outset, I must thank the NCD Division of Ministry of Health and Family Welfare for the kind invite. It's always a challenge to come after Dr. Sarin's impressive talk, but I'll try and do some justice to it. So, my talk is basically how to diagnose and manage non-alcoholic fatty liver disease. A lot of it is covered, and some of it will be a repetition of what Dr. Sarin has said. But just to re-emphasize, non-alcoholic fatty liver disease can be broken up down into the non-alcoholic component and the fatty liver component. So when you define it, it is a person who is not taking alcohol and has fatty liver in the or fat deposition inside the liver. We should always evaluate for any other secondary causes, and if there are no other secondary causes, then this patient has non-alcoholic fatty liver disease. The usual presentation is patient is asymptomatic, and as Dr. Sarin said, it is only by a small ALT test, and that is where we need to define the normal limits to less than 30 and less than 19. And if we do an ultrasound, it will show increased echogenicity. As has already been pointed out, usually the NAFLD or fatty liver is associated with other cardiometabolic problems and metabolic syndrome. And we know that the Asians are more prone to obesity related problems at a lower BMI. So we use a lower cutoff for Asia, as Dr. Sarin pointed out, with a BMI of less than 23 is considered as normal, and we should have a lower cutoff for waist as well. Presence of diabetes, hypertension, dyslipidemia has to be is always associated with fatty liver. Now, we have to find out which of these patients are going to progress for liver disease per se. All the people with fatty liver are having metabolic syndrome and related problems, but some of these patients will tend to develop liver related problems. So most of these patients will have simple steatosis, but a proportion will have what is called as inflamed liver or non-alcoholic steatohepatitis. In this group of patients, non-alcoholic steatohepatitis, the liver disease tends to progress fast and can develop cirrhosis and hepatocellular carcinoma. As Dr. Sarin pointed out, if we assume a 5% prevalence of diabetes, almost 25 million patients are having fatty liver disease currently in India. So most of the patients with fatty liver will die of non-liver related problems. So cardiovascular deaths are the most common, and that is part of the NCD prevention. Second is the cancer related deaths, and only third is liver related deaths that come into picture. We already know that just the presence of fatty liver increases the overall mortality in a group of patients, and so it is important to address fatty liver in any severity. Though the simple fatty liver rarely progress to increased liver-related mortality, it can progress to various cardiovascular-related mortality. But the patient who has NASH has to have liver related further investigations and management. And this is the patient group which has more in liver related mortality and cirrhosis and hepatocellular carcinoma. So what are the medications that we can give? Now, any drug which is useful in non-communicable diseases or lifestyle diseases as fatty liver, the drug should have positive impact on liver-related mortality, cirrhosis or hepatocellular carcinoma prevention, and has to have a demonstrated long-term safety over the years. So both these criteria currently are not fulfilled by the drugs available. So, most of these drugs which are available for fatty liver do not benefit in that aspect. So there are no ideal medicines currently available for fatty liver. So most importantly, we should be understanding that we are not under pressure to prescribe medicines only for fatty liver per se. So what can we do? We have to first rule out for secondary causes of fatty liver. So these are the possible secondary causes. We know alcohol is one of the most common cause of fatty liver, and even if it is in small amounts, can augment various problems. So basically, abstinence from alcohol. We try and test for hepatitis B and C in these patients, and if there are possibility of any other diseases or drugs, we try and test for them. The second step is to treat metabolic syndrome, which is the most important factor in these patients. And we have to optimally treat the coexistence type 2 diabetes with any other drugs. And most of the drugs that are available, metformin or glycosides or the newer GLP-1 analogs, SGLT1 inhibitors, these are all drugs which people who are treating NCDs will be aware of. And the most primary importance is to treat type 2 diabetes. Dyslipidemia, again, obesity is the key here, and we should target central obesity, as Dr. Sareen pointed out, hypertension treatment as well. So besides avoiding alcohol, all these patients should be vaccinated against hepatitis B. Some of them may require catch-up hepatitis B vaccination in the days of universal hepatitis B vaccination. We have to evaluate and treat for other comorbidities. And some of these patients who have NASH will then go on to be referred and go on surveillance for hepatoma. So the key to really liver-related mortality or liver-related treatment would be to identify patients who are at risk of progression and therefore required further treatment and evaluation and specialized management in a more referral center. So how do you pick out non-alcoholic steatohepatitis or the inflamed liver? And that the only real way to do it is a liver biopsy, which is an invasive procedure, very rarely done even in the tertiary center for this indication. So we rely on surrogate markers of both fibrosis and inflammation. And fibrosis are the non-invasive markers, and I'll come to a couple of these which can be done in the peripheral setting. So APRI and FIB4, they are easily done markers in the peripheral setting as well, whereas the more advanced markers like FibroScan and RFI scan or MRI scan will be more related to a tertiary referral units. So this is the APRI score. If you can see, it is relying on two parameters, aspartate transaminase and platelet count, which can be easily made available in the peripheral setting, and a FIB4 score, which is age, again aspartate transaminase, platelet count, and alanine transaminase. So based on these easily available markers in the blood, we can derive the fibrosis score, and these are the various cutoffs which are being proposed by the Indian National Association for Study of Liver. So once we identify based on this patient requires a multidisciplinary approach of management, and we have clinicians and other patient-directed treatment options with dietitians playing a big role at fitness assessment as well. So this is the management strategy which is being proposed by the liver, Indian National Association for Study for Liver, any patient who has NAFLD, fatty liver, will qualify for lifestyle modification, which is diet, exercise, and weight reduction, and I'll come to that. And in addition, has to be assessed for fibrosis with the two markers that we have discussed, FIB4 and APRI. If they are beyond a cutoff value, these patients require more detailed assessment of fibrosis, which is generally by fibroscan, and if possible, and if needed, liver biopsy. Only when the patients have diagnosed NASH with fibrosis do we consider pharmacological treatment more in the tertiary center. But in the early diseases, it's more likely the lifestyle modification, which plays a key role. Always manage the comorbidities, diabetes, hypertension, dyslipidemia, obesity, evaluate for cardiac disease, and as Sir pointed out, sleep apnea and polycystic ovarian syndrome. So what is the diet intervention that we can do? It is, the bottom line is calorie restriction. You have to have calorie deficit. And if you don't have it, the weight doesn't decrease. The main thing is to have a weight reduction to get to the normal weight. So emphasize calorie restriction, which is by limiting the portion sizes, regulate the eating habits, whether individual diet components will make too much of a difference. Yes, maybe a low fat diet, a low carbohydrate diet, avoiding soft drinks, avoiding too much saturated fat may have may have minor differences, but calorie restriction may be the most important. The diet has to be modified to the local usage, and so diet constituents may not be essentially modified. Instead of diet alone, if it is combined by exercise, it works even better. And this is a randomized meta-analysis of 8 randomized controlled trials. And you can see if we combine exercise with diet, and exercise is both resistance exercises and aerobic exercises. Resistance will bring up the muscle mass. Both these exercises, if we combine, it reduces the fat by 50%. As I said, weight loss is the key, and if we have to aim for 5 to 7% weight reduction. If we are able to achieve a 5 to 7% weight reduction, which is sustained, this will result in improvement in liver histology, and that has been shown in multiple studies. The only problem is the sustaining of the weight loss, and both exercise and diet will play a major role in sustaining significant weight loss. The other important factors that lifestyle changes that have to be implemented is avoid nighttime snacking. So that goes a long way in reducing the weight and in improving the liver health. Proper sleep hygiene and optimal sleep duration also goes a long way in these aspects. As far as the drugs are concerned, I think some of them have been highlighted by Dr. Sarin in his final slides. I'll just go through a few of them. As I said, none of these drugs actually stand the test of the two criteria that we said. They are not for long term. And as you can see, most of the drugs have been used for 1 to 2 years in the study. And they are decreasing some aspect of liver disease, but they have not been shown to decrease cirrhosis or hepatocellular carcinoma or liver-related mortality for that instance. So 3 drugs that are being currently suggested by the Indian Association for Liver Studies, 3 drugs that can be given, and more so in patients with NASH only. They are vitamin E, which is an antioxidant. It decreases both inflammation and steatosis, and can be tried up to 2 years in the study protocol. Whereas pioglitazone, which is a PPAR gamma agonist, again a 2-year study which shows decrease in inflammation and steatosis. The saroglitazar is a drug developed in India, and it is a dual PPAR alpha gamma agonist, and we have got 1-year data now which shows decrease in liver inflammation and liver steatosis, and DCGI has approved this for the indication of fatty liver with comorbidities of diabetic dyslipidemia. So saroglitazar 4 mg per day, but again, it is a drug which has been used only for 1 year, only in patients with NASH, so more of a referral drug to be used. There are many other drugs that are available and in the various stages of pipeline development. As I said, 3 drugs, and they are, and I am basically collating evidence or what are the suggestions where various guidelines, European, Asia Pacific, or the American guidelines, and these 3 drugs, vitamin E, pioglitazone, and saroglitazar, most of the drugs we are not having enough evidence across the world to approve it currently. So these are approved by these are suggested by the Indian guidelines currently. The situation is fast changing, and there has been a recent drug which has been approved by FDA. This is a thyromimetic, which acts on the thyroid receptor beta, which are only in the liver, resmetirom, and this is drugs which have been this is a drug which has been approved after a 1-year randomized trial on patients with NASH with a elevated FibroScan value of 8.5 kilopascal. Just to say here that any value of beyond 8 kilopascal suggests advanced fibrosis in these patients. Any value of FibroScan beyond 8 has to be taken as significant. In such a group of patients, when they gave resmetirom for 1 year, they showed improvement in fibrosis to the tune of 25%, and improvement in inflammation again to the tune of 25 to 30%. This drug is currently not very easily available in India. There will be a problem with the cost and applicability to the general population, and the GI side effects will be a limiting factor. Again, as I said, these are drugs which are used for 1 year. We are awaiting long-term safety and efficacy results, but they should come in due course. The 3 other drugs which I would like to mention here, which are in advanced stages of development, are liraglutide, semaglutide, which are GLP-1 analogs, and they have shown to be of some benefit in this group of patients. Obeticholic acid and elafibranor, again, they have shown some benefit, and they may soon have more data for us to suggest what are the changes. There are multiple other molecules which are being tested across the globe and at various stages of development, and I won't go into detail of all this. Just suffice to say, it's a fast moving field, and the prescription for fatty liver per se should be left to specialists which are more tuned to prescribing. The nuances of prescription will be more tuned there. So I will just like to summarize the pharmacotherapy here. Multiple approaches are being tried. None of them have shown long-term benefit currently, but the field is fast changing. So we have to carefully select patients who are more likely to benefit, and better it is to be left to a well-equipped tertiary center for that treatment per se. So for my summarizing here, my presentation, I think the main message would be, even if we diagnose fatty liver, the lifestyle measures are the most important, which can be employed in the peripheral setting, and we should not be pressurized to prescribe for fatty liver. We have to manage the comorbidities. We have to assess patients with liver disease who likely to progress liver-wise, and that is find out a NASH subset, and these patients may require pharmacotherapy, and it's best handled at the tertiary level center. So it's a fast evolving field. So I'm going to leave you there with the current management strategy, and we can take questions here. Thank you.
Sir, thank you so much for that comprehensive discussion on the diagnosis and management of NAFLD, and of course, we have the different pharmacotherapy measures are available, but I think the best pharmacotherapy shall be the reduction in the calorie intake, so as to not to develop. And we are also thankful that you have taken out your precious time from your OPD and given us your insightful experience for the diagnosis and management. Thank you, sir. Now I would like to request the ECO team to put up the next presentation. While the team is doing, I would like to acknowledge the ECO India for their continuous technical IT and digital support which they have been providing to us for enhancing the capacity building in capacity building component of the NCT so as to reach every nook and corner of the country. Next slide, please. So, although NAFED services under NPNCT, Swasti Charan sir in his opening remarks has highlighted all the salient points. I will just quickly run through the slides. So, this is the disease burden as we understand that the community prevalence of NAFED varies from 5 to 32%. It depends upon the age, gender, or the area of residence or socioeconomic status. So, now we are clear that it is one of the emerging important causes of liver disease in India, which needs to be addressed. So also to reduce the burden of other NCDs such as diabetes or CVDs or for that matter CKD as well. NAFED is also the third most common cause of cancer-related deaths worldwide, and a similar trend is seen in India as well. Next, please. Next. This has been comprehensively highlighted, previous one. This slide has been comprehensively highlighted by Sareen sir, wherein the pathogenesis, the environmental factors and lifestyles, which leads to fatty liver, that is the increased calorie intake, the obesity, insulin resistance and hyperinsulinemia. Now we are yes, this already has been taken, that increased calorie intake, obesity, insulin resistance, how it all adds up to fatty liver, and the mantra of eating healthy, eating right, Fit India movement, how it shall help us in overcoming the problem of fatty liver. Next, please. The main risk factor, the main culprit, as we can see, is the increased calorie intake. So then all of it adds on. So we are, it is a proud moment for us that India is one of the first, it is the first country in the world, in fact, to include NAFED under the umbrella of NPNCD program. And on February 21st, 2021, as you can see in the image, the guidelines were released on that day, and the program was formally integrated. Next, please. Now, these are the implementation strategies at different levels of our healthcare system, wherein we follow a bottoms-up approach, right from the PHC to the CHC, then the primary health center, community health center, and district level. So at each level, there are different areas to address the NAFED services, and I shall be covering each of these levels in the subsequent slides. Next, please. These are the broad principles of NAFED under our NPNCD program, wherein we give emphasis on the health promotion through IEC, BCC, behavior support. Secondly, we do active and passive screening, population-based screening to detect cases. Of course, the management of NCDs is done at all levels of care. We are also interlinking it with the other programs. Monitoring and evaluation is a regular feature under the program. Capacity building of NAFED as a part of NPNCD is being done, and we are also the draft training module for the medical officers is also almost ready. The proofreading has been done, so that also comprehensively covers the NAFED part. Public-private partnership and innovations. We are also we do encourage innovations for NAFED component as well. Next. So the subsequent slides now at each level, what services are being offered at the levels we shall discuss. So the lowermost of the ASHA, we do population-based screening by CBAC, community assessment checklist is there, wherein we measure the abdominal obesity and the family history of hypertension, diabetes. We screen for the family history of diabetes, hypertension, heart disease, liver disease, gallstones, etc. And if it is found to be as a risk factor, then the patient is referred by the ASHA to the nearest sub-center, and now we call it as Ayushman Arogya Mandir, as a suspect of NAFLD. When the patient reaches the Ayushman Arogya Mandir or the sub-center, where there the abdominal obesity is measured through the BMI, the family history, personal history is taken by the CHO as well as the ENM. Obesity screening we do for the diabetes, hypertension, and the common cancers. Fetal edema is also measured. And if it is found that the patient needs to be referred to the nearest PHC for diagnosis and management through the medical officer, then the patient is referred. Next, please. At the primary health center, the similar checks are done as were done at the CHC at the Ayushman Arogya Mandir, and specifically the signs of chronic liver disease like spider nevi, Pityaki, purpura, palmar arrhythmia, all of these are also checked. Provision of ultrasound detection of abnormal liver function test to the blood test, as well as detection of steatosis, which is a precursor for fatty liver, is there through ultrasound at the PHC. Most of the PHCs also have a provision of teleconsultation, wherein if the patient has these risk factors, there are fixed days wherein the teleconsultation with the hepatologist from the district hospital or the medical college. So consultation is also taken. If the disease cannot be managed at the CHC, then the medical officer refers it to the nearest CHC, the nearest CHC which comes under which the PHC comes for further diagnosis. Next, please. So at the community, next please. So at the community health center, basically we perform the liver function test. The CBC is done. The risk stratification for advanced liver fibrosis is done for the through the NFS score, and based on the scoring, the low risk and the high risk are characterized. And if the patient falls under the low risk category, then he is reassessed reassessed after every 3 years. And high risk, then the management is done at the CHC itself, or the patient is referred to the medical college or the district hospital. So the filtering of the patient is done at every level. Now, the next we come to the district hospital. The district hospital, under the PIP, we have a provision for the fibroscan. So fibroscan is performed at those district hospitals where it is available. And after the scan, if the score comes and in the low risk category, then the patient is asked to undergo reassessment every 3 years. Of course, he is also advised. The patient is also advised so as to undergo regular checkups, blood reports, blood checkups for the liver function test as well as triglycerides, and also healthy diet. He is advised for healthy diet and regular physical activity. If the fibroscan score falls under the high risk, then we go in for management of advanced fibrosis or screening for hepatocellular carcinoma. And for any further complicated cases, the patient is referred to the tertiary care center, that is medical college. Next, please. Having said all that, the basis of all fatty liver conditions is the excess calorie intake, which leads to obesity. So through the Fit India movement, Healthy Eating, Eat Right India, the government, the Ministry of Youth Affairs as well as FSI, they regularly promote, and Ministry of Ayush to the yoga wellness activities, they regularly promote these activities in the population, so as to prevent the NCDs, including NAFELT. And of course, there is a need that we need to strengthen the interministerial coordination in these activities so that they are repetitively done at the grassroots level and not as a one-time event. Next, please. Lifestyle is something which should be regularly continuously imbibed in the behavior of the individual. Then only the objective can be reached. Quickly, we come to the reporting of the NAFELT services. So there are different forms, the recording and reporting forms. So the form 1A, 1-2 part A, and form part B of 3, 4, 5, 6. So wherein we see the obesity as well as BMI greater than 30. So the person who was screened and suspected referred, like that. So this is one part. Next, please. Now we come on to the monitoring and supervision of NAFELT services. How do we do it? Basically, we have 4 ways of monitoring the NAFELT component. First is the routine program monitoring, and of course under that we do it regularly, and of course state visits are also undertaken, such as the Joint Supportive Supervision Mission, and it is always emphasized whenever a visit to the states is being undertaken. It is always emphasized that the NAFELT component also, along with the diabetes, hypertension, cancer, the NAFELT component also is adequately emphasized upon. Secondly, regularly the data which is being collected from the National NCD portal, there regularly we do the evaluation of the data for decision making. Learning from the latest research in the area of NAFELT and how we can make it more robust. And of course, based on that, the gap analysis, the planning process is done. In the slide, we can also see the different levels wherein the opportunistic screening is done. So I think this is already being covered in different slides. Next, please. Now, this is the capacity building part of the specifically for NAFELT. We have a training cell at NPNCD division, and as I already told you, the draft training modules, we are in the process. They are almost finalized. The proofreading is in the final stages. So NAFELT component has been adequately emphasized in that. Financial support as a part of NPNCD is given for the NAFELT component as well, under the different areas. Next. This is the PIP part explaining the services. States and UTs, there are many states and UTs who have requested for FibroScan at the district level, and they have been approved in the PIP for 24-26. So with this, we come to the end of the presentation. Thank you. So,
I think we can now go ahead with some of the questions if our resource persons are there. So the first thing our esteemed participants are asking is whether we can share your PPTs with them through Gmail. So do we have the consent from 2 of you, sir? Ashish Goel, sir, and Sarin, sir?
I don't mind, sir.
Thank you so much. Then let's pick up some of them. We have got one here. He is asking, is there any role of stress, anger, frustration, and fear in developing disease? I think it's very generic, but one of you would like to answer this in relation to NLP.
I don't think Dr. Sarin is there, but I can take that up. It's a healthy lifestyle. A healthy person will have a healthy liver. All these things will go hand in hand. So a happy person is always good. So please manage stress individually. There can't be a generic information that is there.
Okay, thank you. Okay, how do we manage this program? As you know, that HR status of our district is poor. I think this is an issue which is to be dealt by the division. NHM has the method of rationalization of manpower, and if we have the NCD program up and running in that district, then this is the same unit which is going to be going for NAFLT as well. If not, if the NCD program, the strength is not there, then we will particularly discuss with this district. We can notice, and you can reach out to us to your state nodal officer, and we'll try to do it.
Here, I would like to add that we do have our NCD clinics, individual across all districts. And the answer here more lies in training and more training of our Arogya Mandir, PHC, HSC staff, the CHO, the team, the Ashas. So I think we have to emphasize from our team here and the states also to emphasize more on training. That is the way we can build up their capacity and enhance our manpower. Thank you.
Thank you. There is some more questions, Ankita, if there are any questions. Sir, Ashish Goyal sir, someone is requesting diet के बारे में बताएं. I think we have covered some of them. Would you like to repeat some of them here again?
Okay. There are no specific one size fits all. It has to be local dietitian, local development of diet. But overall, overarching aim is calorie
Restriction.
I think as Sari is saying that the main part is the calorie
suggest
control. So, yes,
calorie
sir.
restriction.
Okay, so the next question here is stage 2 fatty liver can be reversed or not?
These are lifestyle diseases again, which we are not aiming for reversal. We are aiming for management and follow-up of these patients. So it's like diabetes. Can it be reversed? It can be going on without drugs, but yes, we have to keep on follow-up.
Okay, thank you. I think one more question here is statins. I think he's asking to ask whether statin is a cause of diabetes mellitus.
Okay. Statins is a cause of diabetes mellitus. No, statins are used for treatment for high lipids, hyperlipidemia, dyslipidemia, and can be given in patients with fatty liver if there is dyslipidemia. So statins are useful and in most of the patients with fatty liver, if indicated.
Okay, thank you. And one more question.
Can I take
this one? Yes, Dr.
Sir, can I ask you one question, sir? Like 12% of the population which was screened in Delhi, as Dr. Sareen said, and was found that they were lean and thin as compared to majority of the people who have NFLD. So in those particular people who do not have risk factors like obesity and weight, and so what should we advise them regarding their lifestyle management and other things? So can we have a control over those, or there is something like genetics or some other things which are causing that thing?
Yeah, no, thank you for the question. It is genetics may play a role, but we can't control genetics. So what we can do is control the sort of get the visceral fat better and the muscle mass better. So your ratio of muscle mass to visceral fat, your weight may be correct, but your visceral fat may be higher. So you still have calorie restriction and you still have exercise, both going hand in hand to correct that imbalance. That is, I think, the way to go.
Yeah, so I think that exercise in those patients will help more than the dietary restrictions. No?
Yes, I think both of them will have a big role in that patient to correct the imbalance.
Thank you, sir.
One more question has come, sir. Here it's the
Semaglutide.
semaglutide we use for overall metabolic disorders.
Okay, so there is more and more data coming on semaglutide and liraglutide, which are GLP-1 agonists. So basically, they are for diabetes and obesity, and they are the fashionable drugs currently. They are quite costly, but again, they are for diabetes and obesity. If indicated, then they can be used for that. Their exact role in fatty liver per se needs more evaluation, but yes, for metabolic syndrome, yes.
So one more question which has come here is, the question is, I come across few doctors prescribing some herbal compositions like leaf 52, leaf fit, etc. How useful are they for liver function?
It's beyond my capacity to answer yes or no. We generally don't give and encourage herbal medications, but beyond my capacity.
Can we take some more? Is it necessary to have a fibroscan? This is a common program-related question usually asked. He's asking, is it necessary to have a fibroscan available at the district hospital, or are there any suggested alternatives?
I can talk about the.
Can I also just add one more to this? So, what percentage of people who have elevated ALT, like you said, would be needing a fibroscan, like at a community level, in a general scale? Will also help to answer this, please.
So generally, if you see a population-based fatty liver study, around 5 to 7% will have NASH, and these are the people who will benefit from liver-related interventions, NASH. So I wouldn't expect more than 10% of whatever we screen to be actually being benefited by FibroScan. I would suggest a more nuanced approach of AST, ALT, platelet count at a local center, and only when they have more chances of fibrosis, they go on to develop or go on to have FibroScan quantification.
So I think that way we should be looking more at program level of ALT testing. That way, I think.
Even Dr. Sareen also indicated.
Yes, I
ALT
think
testing.
that should be, yes, one of our next step. Till now, we have been looking at, we have trained ASHA workers, all those hip waist ratio and other things in that form. But next level, I think we should look at this.
So I think with this, we come to the end of this webinar, and the program division, ma'am, we are very thankful to respected Additional Secretary Madam for being with us.
I'm very thankful, especially to Dr. Sareen and Dr. Ashish Goel. I mean, everyone, we are all like so intently listening, and we are so engrossed in this presentation. It's really been enlightening and very, very interesting. I'm very thankful for my side.
Thank you, ma'am.
And for the participants, the speakers who have joined from all over the medical officers from different district hospitals and CHCs and PHCs. So with this, we come to the end of the webinar. Thank you, ma'am. Thank you, Swasti sir. Thank you, Deputy Secretary Madam Satyanarayana ma'am. So thank you everyone.